Hi guys, this is Amrit and I'd like to welcome you to OSPRO Ed. This video is for educational purposes only and please never practice medical skills without the proper credentials. Our topic today is kidney stones, also known as urolithiasis. Stones form throughout the urinary tract. They're common presentation to the ED and GP setting. The most frequent presentation to the emergency occurs when the stones migrate down the ureter. This actually is quite painful, and we call this renal colic. A friend of mine recently had a kidney stone and he asked me, what position is good for me to be in to pass the stone out? And I said to him, buddy, this is not childbirth or labor. But jokes apart, from what I've seen, it can be excruciatingly painful and no less than a labor pain for those who undergo this. Renal colic is an important topic in abdominal pain, and our goal is to be able to form a diagnosis and also have a good sense of knowledge to differentiate between other serious causes of abdominal pain. This includes abdominal aortic aneurysms, infarcted bowel, peritonitis, and other surgical, gynecological, and urogenital differential diagnosis. Always think of the organs and anatomy, and your differentials will come to you naturally. In ED setting, we aim to avoid CTKUB in an otherwise healthy, less than 50 years old, known history of calculi presenting with uncomplicated renal colic. In deciding whether a CTKUB should be ordered, to make a definitive diagnosis, we ask ourselves a few questions. Number one, does the patient have one or more red flags? So what does that mean? So what are the red flags? So flags, FLAG, so F for fever, L for loss of renal function, A for analgesia, so high or ongoing analgesic requirement, and G for age, so age of more than 50. So flag, okay? Once we know it's possible renal colic, the patient goes from emergency department to either the emergency department short stay unit or they are admitted to the general ward under the supervision of the urology inpatient unit. If, say, the patient is in emergency, we usually follow the 4-hour rule to avoid overcrowding the emergency department. So we have a time slot of 4 hours, and in 4 hours, your patient either needs to get safely discharged home or get accepted to another department and transferred under a medical or surgical team or transferred to a short stay unit. To go to a short stay unit bed, there are admission criteria, and if the patient meets those, then they can be sent to the short stay unit. Whenever you're working in emergency, you always need to keep in mind that you're not working alone. You're working as a team. So it is important that you notify your nursing staff, the authorizing officer who is the ED boss of the shift. And also once you've handed over to the short stay unit doctor and got an approval that they've accepted the patient, then let the flow coordinator know and they can do all the arrangements for the transfer. And talking about short stay unit, so the admission criteria for a patient to go into a short stay unit on a renal colic pathway would be, say, somebody with loin colic due to renal tract calculi, hematuria. And also, every hospital has their own set of pathways, and some hospitals have short stay units where some don't. So just so you know, ideally, if, say, a patient did go to the short stay unit, they can stay there longer than 4 hours. So the target outcome for patients to go to short stay is so as they can either be discharged home safely and they can be monitored for 4 to 6 hours. We can make sure that they're pain free. We can make sure that they have had their investigations like a CT or like urology has come in and had a look at them. They've had like enough prescriptions to last them a couple of days when they go home. And also we know that appropriate self-care can take place and that the patient's got support available at home. To send somebody to short stay is one thing, but also we need to make sure that, they don't have any exclusion criteria that prohibit a patient's admission into the short stay. So these are things like, likely length of stay for more than 24 hours. Say that, a patient had hematuria and renal colic, but they also had some other issue. So we're thinking, yeah, maybe this patient may need to be stuck here for more than 24 hours. So that's not a good, indication for us to send them there. If somebody had unstable vital signs, if somebody had, say, a single kidney or a horseshoe kidney or ureter abnormalities, if they had abnormal renal function or the stone is quite large, like more than 5 mm in size, these patients will require a referral to the urology inpatient unit for management during a longer inpatient stay. So in that case, we do not think about short stay. Your simple, straightforward cases of renal colic can be sent to short stay, and usually, you let the urology know that you've got this patient and they're happy to come and see them in short stay, make a bit of a plan for imaging and outpatient follow-up, and the patient usually goes home from there. When it comes to renal colic and the pain, you need to be aware that there are some patients that will mimic a renal colic. And when you have a renal colic walk into the ED, you need to be a bit careful because there are some opiate addiction patients, and they may present mimicking the symptoms of renal colic in an attempt to obtain opioids. And this is generally considered to be a very small percentage of the total number of presentations. So it's not something that happens so often, but it is something that you need to think of as well. And before giving somebody pain relief, be aware of contraindications, especially to NSAIDs, absolute or relative contraindications. Seek advice if you're unsure. And just so you know, obvious contraindications to NSAIDs will be like allergic or anaphylactic reactions, a history of stomach ulcers or GI bleeding, a patient on warfarin or other anticoagulant therapy, somebody taking regular NSAIDs prior to the presentation, somebody who is pregnant, somebody who has asthma caused by anti-inflammatories, patients with poor kidney function and cardiac failure. Some of the issues to consider, well, whenever you remember renal colic, keep in mind that it is a great mimicker of AAA. When you have a renal colic walk into the ED, the first thing you want to do is an initial triage assessment and a quick management. So pain relief should be administered promptly. NSAIDs should be included as first-line therapy, ideally initiated by the triage nurse within the first hour of presentation to the ED. When you take a history, well, on history, you will see that they complain of severe loin to groin pain. The pain may radiate from the loin to the scrotum or labia or inner thigh. Pain is colicky. Patient is unable to obtain a comfortable position. Associated nausea and vomiting could be there. They may have dysuria, frequency, hematuria. They may have fevers, sweats, rigors. These are usually suggestive of pyelonephritis, but it may or may not be there. Upon examination, the temperature and vital signs need to be checked. The pain scoring needs to be assessed from 1 to 10. This should be done right away. You'll need to palpate the abdomen for tenderness in the loin and the anterior abdomen. Check out if there's any rebound or rigidity or peritonitic signs. Examine specifically for AAA, especially in patients more than 50 years of age. And if it's the first episode of renal colic, make sure that you check the FWT, the full ward test, for blood or signs of infection. Hematuria may be absent in about 15% of cases, and presence of hematuria does not exclude a AAA. Speaking about investigations, urgent abdominal ultrasound needs to be done if there's any possibility of a AAA, and the ultrasound is usually done at the bedside. A full ward test for the urine, you may see RBCs in 85 to 95% of patients. If the full ward test suggests immediate evidence of infection, for example, it's positive for nitrites or leukocytes, then pyelonephritis or sepsis should be immediately empirically treated with appropriate antibiotics. Full ward test is an unreliable investigation and should not be used in isolation to rule out or rule in renal stones or infection. MSU should be done on all patients' urine specimens. So a copy of the results should be forwarded to the patient's GP and the urology specialist so as they can follow up, as the results will generally only be available after 48 hours. So you can let the patient know that we're doing a culture on their urine and make sure that they follow this up. Making sure that next we also think about bloods. So FBE, UNDs, creatinine should be done on all patients. So a serum uric acid and calcium levels are recommended options. Speaking about imaging, x-rays, so 90% of urethral stones are radio opaque, which means they are visible on plain x-rays. CT-KUB, so non-contrast CT scan is the best way to evaluate for the presence of urolithiasis. It is more accurate than intravenous urogram. So a KUB X-ray, ultrasound, and MRI can be done, but we aim to reduce unnecessary imaging. This will have an impact on both the cost and the quality of care and the radiation burden. So we need to be very careful on what imaging we're choosing and why we're choosing this. We aim to avoid CT-KUB in an otherwise healthy, less than 50 years old, known history of calculi, somebody who's presenting with uncomplicated renal colic. In deciding whether a CT-KUB should be ordered to make a definitive diagnosis, the questions should be made, and the questions are the red flags. So as I spoke before, flag, FLAG. So is there fever? Is there loss of renal function? Is there a higher or ongoing analgesia requirement? And is there an age greater than 50? So if that's the case, then yes, definitely we can think about CT-KUB. Other indications for a CT scan, well, do you suspect a large renal tract calculus or obstruction? And the patient, is he or her stable enough to go to the radiology department? Is the patient febrile? Does the patient have a solitary kidney? Or does the patient have any other renal tract abnormality? For other presentations of renal colic, or like for those that are managed in a short stay unit, an outpatient CT-KUB can be ordered after they are discharged. This should be performed within 2 weeks of their presentation and prior to the patient's review at the urology outpatient clinic. Ultrasound is sensitive for detecting obstruction but not stones, and it is less reliable in detecting alternative diagnosis such as AAA. IVP or CT IVP, if requested by the urologist, can be done. So in ED, we don't do that. Initial KUB x-rays may be performed to diagnose larger stones, like greater than 5 millimeters. And standalone, like KUB x-rays, will not be reliably able to diagnose a renal calculi, but may be useful to follow up a proven radio-opaque stones. We can strain or filter all urine that is collected, and that helps to analyze the stone composition. This may be crucial in the ongoing management to find the underlying cause for recurrent renal colic. When it comes to management, so the first thing is pain relief. Pain relief should be administered promptly. NSAIDs should be included as first-line therapy, ideally initiated by the triage nurse within 1 hour of presentation to the ED. In order to appropriately commence analgesia, make sure that you follow the local guidelines of your hospital. So, for example, in my workplace, we differentiate between mild, moderate, and severe. So, if it's a mild pain, say it's a score of less than 3/10, we can give paracetamol and ibuprofen. If it's moderate pain, that's a score of 4 to 7, we can give paracetamol, oxycodone, and ibuprofen, or diclofenac or ketorolac. If it's severe pain, say a score of 8 to 10, then paracetamol, ketorolac intramuscularly, and morphine IV. This can be titrated to effect. Again, go and follow the local guidelines of wherever you're working. The second most important thing when it comes to management is IV access. Make sure that you have good intravenous access, but remember, a fluid bolus may increase pain. So getting an IV does not always mean that you're pushing fluids. Just make sure that you've got vascular access, and if needed, you can use this. The third thing is antiemetics. So things like ondansetron can be given to help with any nausea or vomiting. The fourth thing is encouraging oral fluids. So making sure that the patient can, tolerate fluids orally. The fifth thing is antibiotics. If there's any evidence of infection, then follow your local guidelines and make sure that you can give them some antibiotics. Number 6 is the urology follow-up. So different workplaces have different sort of criterias, but at our hospital where I work, the urology requests that there is a outpatient follow-up organized in 2 weeks. So every hospital has their own processes, but ideally speaking, about a urology outpatient department follow-up, this is happening at about 2 weeks time. And if it is a serious case, urology will admit the patient under their care. If it's someone who needs surgery, or if there's like a definitive urological treatment that has to happen, they will undertake all of that. However, if it's something that can be managed as an outpatient, then they would expect that from the emergency department, at least the patient has an outpatient follow-up organized. Alrighty. The other thing about management is Buscopan, antispasmodic agents. So guys, there's no evidence that antispasmodic agents like Buscopan are effective for renal colic. Alpha blocking agents like tamsulosin may reduce pain and can increase the passage of the stone. However, this is an authority prescription for which renal colic is not an indication. It's an expensive medication, and there may be some adverse drug interactions. So unless it's coming directly from urology, that's okay. But I would not start somebody on tamsulosin on my own. When it comes to discharge planning, the discharge plan should include arrangements that have been made for the follow-up in the urology clinic or in a consultant's private rooms. Patients in Australia can see consultants directly in their private office, provided, they've got the means to do so, either private health insurance or enough money. Patients should strain or filter all of their urine that is collected to analyze the stone composition. So we usually recommend that, once they go home, they use a strainer and try to catch the stone. And upon discharge, we also try to give them a container that is labeled, as well as a pathology request slip. So if they catch their stone, then they can send it to the lab and we can find out what type of stone this is. When it comes to repeat imaging, you try and follow whatever the urology department advises. So if they want a repeat KUB CT or x-rays, then you can order them and the patient can have it before their consultation. Speaking about stone types, some stones are calcium stones, and these are usually like calcium oxalate or calcium phosphate, and these can be seen on plain x-ray. Then we've got uric acid stones. So these commonly form due to like excessive high protein diet, obesity, or patients who suffer from gout or uric acid stones. These are not visible on x-ray. So keep in mind, there are some things which are visible on X-ray, such as calcium stones, and then you've got uric acid stones, which are not visible on X-ray. Then you've also got cystine stones. These are radiolucent and are not visible on X-ray. They occur in 1% of stones, and they happen due to the inherited defect in amino acid transport within the kidney. An excess of cystine crystals are found in the urine of the affected patient, which clumps together to form the stones. Other than this, we've got struvite, which are little stones formed by infections, and there would usually be a history of UTIs. Okay, so speaking about surgery, when a patient follows up with urology, they may or may not be a candidate for a surgical intervention. Usually, this decision comes from urology. So if there's a renal colic that's failing medical treatment, or the stones are associated with anuria, or there's a single kidney or bilateral obstruction, or acute renal failure, or associated infections, this would require a surgical decompression of the affected kidney. Options include cystoscopic retrograde stent insertion or a nephrostomy tube insertion with or without antegrade stenting. If there is no evidence of infection, it is feasible to attempt a primary laser lithotripsy of the offending calculus. Whether or not a person gets a surgical intervention is 100% decided by the urology team, depending on their guidelines as well as the patient factors. All right, everyone. I hope this was useful. Please don't forget to hit the like and subscribe. Please feel free to leave comments on what type of videos you'd like. And if there's specific topics that you'd like me to make videos on, I'd be more than happy to do so. I hope this video gave you a good understanding on renal colic, and I hope that this was useful. I look forward to seeing you in another video. Until then, take care of yourself and be kind to those around you. Thank you.